Morning, students. Today we are going to discuss one next topic of the respiratory system, that is lung volumes and capacities. Some introduction of the pulmonary function test. Now, till now, what we have seen is functional anatomy of the respiratory system, and we have seen in detail the physical factors, the mechanism of respiration, how the lungs and the thoracic wall all together are going to perform the function of ventilation. Now, as we have taken inside the air, that is pulmonary ventilation, what should be the ability of the lungs to have these volumes and the capacities in it? That is the main session topic. The capability of the lungs have different volumes and the capacities to inspiration and expiration. So we are going to discuss different volumes and capacities, and along with that, some pulmonary function tests. Again, this topic I'm going to record into different sessions, but this complete topic is asked in the examination. The big community communication which is asked in the examination. Just for understanding purpose, I'm separating it into B. So let us discuss what different type of lung volumes and capacities are. So if we consider broadly, these lung volumes and capacities are divided into two parts. One is static lung volumes and capacities, where the time factor is not involved. It is generally expressed in milliliters or liters. Whereas if it is changing and time dependent, then these lung volumes and capacities are known as dynamic lung volumes and capacities, where they are expressed in milliliters per minute or liters per minute. So broadly, two classifications of these volumes and capacities: static and dynamic. How these EFPs, the pulmonary functions, the volumes and capacities, are categorized if you want to find out what is the ability of them. So again, clinically, the pulmonary function tests are divided into four types of pulmonary function tests. So for assessing the lung functions, we do the pulmonary function test. So first and the most important pulmonary function test, we can assess the mechanical ventilatory functions of lung and chest wall. Then, where we can assess the static lung volumes and dynamic lung volumes. And these are the different static lung volumes and dynamic lung volumes. EFT will be broadly classified into these categories. Mechanical ventilatory functions can be assessed by moving the static lung volumes and capacities, dynamic lung volumes and capacities, or we can go for ventilation test. The second part is the gas exchange test. So we can do the pulmonary function test or by doing the gas exchange across the alveolar gas membrane. So we can find out the arterial partial pressure of oxygen, and then we can find out the gradient, alveolar arterial gradient. We can find out the diffusion capacity. We can go for gas distribution test. These are very difficult tests and they require a sophisticated environment, sophisticated instruments. And these gas distribution tests, the single breath nitrogen test, multiple breath nitrogen test, helium dilution method, in your guidance in genome, in of course in the PK chain also. These are the tests are given in go through it, not going into detail regarding these tests. So these are the gas exchange tests. So pulmonary function can be assessed by either finding out the gradient of pressure, diffusion capacity, gas distribution test, or we can go for ventilation perfusion test. We can find out the arterial blood gas analysis. We can go for single breath carbon dioxide elimination. So these are tests which are done if you want to move the lung functions in detail of that particular patient. The third type is cardiopulmonary interaction. Here we can go for qualitative tests, so we can find out by taking a detailed history. We can do the clinical examination in detail. We can find out the arterial blood gas analysis, or we can go stair climbing test. These are the qualitative test. You can also go for quantitative test, which is nowadays very famous. You might be aware of this. That is 6-minute walk test, which is known as gold standard test, and this is a cardiopulmonary interaction. So these are the categories of event. Now, why these EFTs are done? Why you want to find out the rate of marks? Most of the time, it is for prediction of the presence of pulmonary dysfunction, different type of diseases. Try to know the functional nature of disease, how far it is progressed, what is the improvement that we want to do. Whether it is obstructive, inside there is an obstruction, or whether it is restricted from outside there is restriction. To assess the severity of the disease, to assess the progression of the disease. If you are giving any type of treatment, what is the response that we can assess by finding out this? Then we can find out the patients at increased risk of morbidity and mortality, those who are going for pulmonary resection. If a patient is there on ventilator in the ICU, and now we want to detach the ventilator and shift the patient into the normal ward, then from that process is known as weaning of the patient from ventilator in the ICU. Before that, we can go for this medical legal to assess the lung impairment as a result of occupational hazards. So many occupational disorders are there. For example, effect of pollution, cement factory, effect of brick workers. So the exposures are there, and we can assess the lung impairment for occupation. Many types is done as an epidemiological service to assess the hazards to document the incidence of disease. For example, capacities. You are always in the crowded area. Here we can do the epidemiological service. And to identify the patients of perioperative risk of pulmonary complications. So before doing any major surgery, if you are suspecting that there may be a pulmonary complication, you can go for these complications and then assess the risk of these complications. So these are the needs which is very commonly again asked in the examination and very important, very much important for career also. So in the past, what we were doing was with the help of the stethoscope, we were finding out the presence or absence of air. The picture is the first stethoscope which is used. Okay. So what we can find out is presence of air in narrowing, whether there are cavities in the lung, but with the help of the stethoscope, there is no real objective measure of the lung function. It doesn't give a detailed idea regarding the lung function. What it gives is only whether there is an air in narrowing or whether there are cavities in the lungs. So it was not supposed to be useful. A general method by which we can always find out this thing is that how strong are your lungs. So, say for example, you can at one stretch if you can this how many candles are there. So you can blow off all these candles, and then we can find out how strong candles are. This again doesn't give any good idea regarding the lung volumes or the lung capacities. Then, depending on the Archimedes principle, we try to find out the volume of displaced water, which is equal to volume of air in the balloon. So that was the first in 1727 Stephen Hills tried that if this is the thing, we depending on the Archimedes principle, we can know the lung volumes and capacity. Now, after having so much of research, Sir John Hutchinson in 1846 discovered this parameter, which is known actually discovered in 1852, and this is the picture of this parameter with the help of which the volume of air an individual inhales or exhales as a function of time can be found. So it was able to measure the vital capacity, more sensitive to detect the tuberculosis than the use of stethoscope as a auscultation. It can predict the life expectancy, and this was suggested as a routine test for life insurance cover. So since then, many instruments were developed, and nowadays we are using these type of machines to know the lung volumes and capacity. So these are PFD machines. The left side machine is a very handy machine which is available in our department also. If you are physically coming, you have to do this practical. It is there in the examination. So this is pulmonary function test which you have to see this. The water spirometer, the previous one, that is also there in the examination. If you have the chance to come again for the physical practicals, you get to know all these instruments. And again, in the medicine department, in the ICU department, these handy machines are always available. The right side machine is also is there in our department. Again. This is known as body plethysmograph, where we can find out in detail the lung functions, along with the flow volume curves. We can find out the airway resistance and different parameters. The gas diffusion also, the gas distribution also. So that can be done with this body plethysmograph. Again, this instrument or this PFTs are done in our department in the hospital. So this is the graph which we get when we record by any of these type of instruments. So this is the basic graph which is recorded by water spirometry. And this water spirometry, this particular graph is known as spirograph. And here you have to ask the subject to sit up comfortably and you have to keep the instructions and then the record is often. So you get a record, those red lines will be the recordings. Inspiration is recorded as an upstroke and expiration is recorded as an downstroke. And this on the vertical axis, it is a lung volume. Actually, the spirograph is a calibrated graph. So each small square bead will be of 100 milliliters. So you can directly measure by just seeing the graph itself, the volumes. And on the horizontal axis, the time is. We can adjust the speed of the machine. So this type of recording you are getting. You can see there are different volumes are given and there are different capacities which are shown in this. This graph is again very commonly asked in the examination. Draw the spirometry graph showing all lung volumes and capacities. So this is what you have to draw along with the explanation which we are going to discuss. So what are these lung volumes and capacities? The PFD dressings are showing four lung volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So these are the four volumes which can be recorded by these lung volumes and capacities. Now you are using the water spirometer. The one of the volume is not recorded here, the residual volume. But this residual volume in the computerized spirometer, those who are newer spirometry machines can be recorded. So what we can see here in this is if you ask the subject to breathe quietly, this type of recording you are getting. So this is inspiration, expiration, inspiration, expiration. The quiet breathing and continuous breaths are there. Now this amount of volume change here either in inspiration or expiration is termed as tidal volume. This is what is tidal volume. The volume which you can see here. So this is tidal volume. Then if you are asking the subject to inspire as far as it is possible for him. So you will take a deep breath and you will get a recording like this. So this will be your inspiratory reserve volume. So over and above the normal inspiration, whatever amount of inspired volume is recorded is your inspiratory reserve volume. And this is the volume which is over and above the normal expiration. So you have this expiration normal and the amount of air which is expired over and above is expiratory reserve volume. So these three types of volumes are recorded with the help of water spirometry. Now, after complete expiration, forceful expiration, still some amount of air is always remained inside the lungs, and that volume of air is known as residual volume. So this residual volume recording is not possible with the help of a water spirometer, but these are the four volumes which are lung volumes which we can calculate. Now the combinations of these volumes will be the five capacities. So you get the inspiratory capacity, vital capacity, and functional residual capacity. So inspiratory capacity will be tidal volume plus IRV. Expiratory capacity will be IRV plus tidal volume. So this will be expiratory capacity. And vital capacity will be inspiratory capacity, inspiratory reserve volume, tidal volume, and expiratory reserve volume. So three together will be giving the vital capacity. Now what is remaining is residual volume. So if you add the residual volume to the vital capacity, it gives the total lung capacity. Now what is remaining is residual volume. So if you add the residual volume and expiratory reserve volume, this gives the value of functional residual capacity. Now, maybe at first it looks like a complicated thing, but if you are able to see physically, or if you undergo this particular graph in detail, it's very easy to remember. Four lung volumes, the definitions and the normal values you have to keep in mind, and five capacities. So first, one by one, we are going to see. We have discussed, but now again, let it be repetition. The volume of air inhaled or exhaled with each breath during quiet breathing. So either inspiration or expiration. So that will be your tidal volume. Normally, it is 6 to 8 ml per kg. What is inspiratory reserve volume? Is the maximum volume of air inhaled from the end of normal tidal inspiration. So this is normal tidal inspiration. So from this, whatever maximum amount of air which can be inhaled is your inspiratory reserve. Normally it is 1900 to 3300 milliliters. Now 1.9 to 3.3 liters. And expiratory reserve volume is the maximum volume of air that can be exhaled from resting in expiratory tidal position. So from this will be resting state, and up to maximum level will be your expiratory reserve volume. Generally, it is 700 to 1000 milliliters. Then we have the residual volume, the volume of air which is remaining in the lungs after maximum exhalation. So you ask the subject to do the maximum exhalation, still some amount of air is there, and it is generally 20 to 25 milliliters per kg, and that is 1.7 to 2.1 liters. It is indirectly measured by from the FRC minus the ERV, or cannot be measured as we have discussed by water spirometry, but with a recent instrument we can record this. Then coming to the lung capacities, we have the total lung capacity, which is the sum of all volume compartments or volume of air in the lung after maximum inspiration. Sum of all volumes, IRV, TB, ERV, and RV is your total lung capacity. That is around 4 to 6. Whereas vital capacity will be total lung capacity minus the residual volume. So except the residual volume, the remaining volumes, the IRV, tidal volume, and ERV will be your vital capacity. And this is 3.1 to 4.8 liters. You have the inspiratory capacity, sum of IRV and TB, and that is around 2.4 to 3.8 liters. Whereas expiratory capacity is the tidal volume plus ERV, which is around 700, 1.2 liters, around 1.2 liters. Then coming to the functional residual capacity, which is sum of residual volume plus ERP, and that is around 2.3 to 3.3. This is measured by closed circuit helium dilution or open circuit nitrogen washout or body values. Now, it cannot be measured by spirometry. So that is, these are the different long volumes and capacities which we have to remember. So whatever mechanism of pulmonary ventilation with the help of all thoracic wall, lungs, the muscles, the pressure changes, everything will be possible to have these much of changes in the volume. And these volume changes are divided into these lung volumes and capacities. We are going to discuss in detail what is vital capacity. Because separately a question can be asked on this vital capacity. Maximum volume of air which is expired after a maximum inspiration. So both the phases are maximum. It is denoted by typing volume plus expiratory reserve volume plus IRV, and it's around 3.1 to 4.8 liters. It's considered to be abnormal if it is less than 80% of predicted values. The factors which are affecting the vital capacity are physiological. The first is physical dimension, which is directly proportional to the height. Sex, it is more in males due to larger size, more muscle power, and more body surface area. Age, it increases with the increasing age, and also very importantly depends on strength of respiratory muscle. In the posture, this very important factor that it decreases in the supine position. This is very important factor that vital capacity is decreases in the supine position. Nowadays, you might be knowing that the oxygen saturation is decreased. There is hypoxia in the COVID situation, and you might be aware that different positions are given to the patients, and these are known as CARP position. That is CARP, CARP protocol. And these are the different positions where you can have maximum ventilation possible so that the oxygen saturation is maintained. And it is said, or it is known by different research work, that just by giving these different positions, we can have a better oxygenation, and many a times the moderate type of COVID is recovered and they will not require the ventilation or ventilators or ventilator assessment or improvement in the oxygen saturation. Home isolated patients also are benefited by this particular CARP protocol. Again, it's my request, if anyone is interested, you can send the CARP protocol, what exactly it is and how to follow it. Because now all of you are also a part of medical fraternity. So as far as possible, if you are saying or communicating to these patients, those who are affected with the COVID, just by simple posture, we can improve the health. Then pregnancy unchanged or increases by 10%. So generally this is not affected in pregnancy. But pathologically, diseases of the respiratory muscles, abdominal conditions like pain in the abdomen, distension of the abdomen can affect the vital capacity. The factors which are increasing the capacity are there may be alteration in the muscle power due to use of drugs, neuromuscular disorders, cerebral tumors, different type of pulmonary diseases like pneumonia, bronchitis, asthma, fibrosis, emphysema, pulmonary edema. So all of these factors can affect the vital capacity, and thus there is difficulty. There may be space occupied lesions in the chest like tumors or pleural pericardial effusions, kyphoscoliosis, and that can lead to discomfort in breathing. Abdominal tumors and ascites of course will be the vital capacity. One more important factor is functional residual capacity. This is the volume of air remaining in the lungs after normal tidal expiration when there is no air. So still the lungs will be having some amount of air, even if they have maximum expiration. So generally it is 2.3 to 3.3 liters, and it is found out by residual volume plus ER. It is seen that it is decreased under anesthesia. With spontaneous respiration, it is decreased only by 20%. If there is a paralysis of respiratory muscle, it decreases by 16%. The FRC is increased with increased height, in erect position, decreased lung recoil, and it decreases with obesity, muscle paralysis, supine position, restrictive lung disease, and anesthesia. But it is not changed with age. The vital capacity does change with age, but the functional residual capacity is not changing with age. It remains the same. So these are the factors. Other than that, age, other than that, these are the factors which are affected. Now, what is the use of these FRC? Why we want to have some amount of air? Acts as an oxygen store. It also maintains a steady arterial partial pressure of oxygen. So it is a buffer for maintaining that pressure. It helps in partial inflation to prevent the atelectasis. And the most important is that it minimizes the work of breathing. Otherwise, again, I am giving the same example that if it is not inflated with this functional residual capacity, the alveoli, every inspiration will require a maximum work of breathing just for inflation. So remember, if you are inflating a balloon, it requires less work of breathing if it is already inflated, but if it is not at all inflated, it requires maximum work or maximum pressure change. So that is minimized with the help of FRC. It also minimizes the pulmonary vascular resistance, and it keeps the airway resistance low. So thank you very much. This is the first part of the lung volume and capacity. In the second part, I will be dealing with the dynamic lung volume and